Hey folks, Scott Weingart here, and this is an EMCrit WE. It's actually a CV-EMCrit, cardiovascular EMCrit WE. This is the first of two parts of discussion of electrical storm. And I'm joined by Trina Augustin, who at the recording of this podcast is very pregnant, but at the time of publication of this podcast has a beautiful baby boy. And we first discussed electrical storm for general ED and critical care patients. We'll do a part 2 where we'll actually discuss electrical storm for patients already on VA ECMO. That will be of interest to a more limited audience. This one should be of interest to everyone. So I've already had posts and podcasts on EMCrit for stellate ganglion block, which we cover very briefly here because there's a complete podcast on it, and on dual sequential defibrillation, which I have 2 separate podcasts and posts on with Sheldon Cheskis. So you should check all those out. But I realize we don't have any context for those. Now we do. This is a fantastic discussion on the therapies, the antidysrhythmics, when to call for ECMO, all sorts of stuff for electrical storm. So I know you're going to love it. Welcome back, Trina. And folks can't see you because we're audio only, but you're more people than you were last time. People might have listened. Trina, what point in your pregnancy are you at, if we're allowed to say it on the air?
I'm officially 38 weeks and counting the days and maybe even hours till this little guy comes out.
Oh my God, I hope it doesn't interrupt the podcast recording. But if it does, we will get her back 3 or 4 weeks from now. All right, Trina, fantastic. Thank you for doing this despite the advanced pregnancy. And we had last spoken with a topic that was outside of your real areas of love because it dealt a lot with the lungs. But now we're back to the heart. So you have to be a happy camper.
I'm so happy.
All right. So we're going to discuss electrical storm. Now, you looked at the incredibly detailed, wonderful post you had wrought and said, Scott, I think we should split this up because some of this is going to be applicable to everyone and some of it's really going to be applicable only to cardiovascular intensivists. So that is what we're doing. So part 1 will deal with electrical storm prior to the placement of VA ECMO and the candidates that may benefit from VA ECMO. And then part 2 will discuss electrical storm for a patient already on VA ECMO. And everyone should listen to part 1, but then you make the decision if you want to listen to part 2.
Sounds great. I definitely felt like I had to give my cardiovascular intensivists a little bit more of the nuanced therapy. And part of that's because my surgical teams keep asking me to dive into this. But I realized after listening to so many of your recent incredible posts that we have this amazing data out there on stellate ganglion blocks and dual sequential defibrillation that my initial focus had just been, we should just talk about VA ECMO on these patients. But what I realized is it's really important, especially for emergency medicine doctors and critical care doctors who are dealing with this up front, to have a really good algorithm and pathway to start and make sure they have concise, excellent guideline to management of these patients, and then walk them into when should I call for VA ECMO and who would be great candidates for it.
I love it. I love it. So we're going to try to keep this relatively concise as much as we ever do on CV-EMCrit. So if there's something that we've given slightly short shrift to, it's all in the post. It's always all in the post. So don't consider the podcast complete in and of itself until you've checked the post. All right. So Trina, what is electrical storm by current definition?
Absolutely. So currently, most people are going to consider it equal to or greater than 3 episodes of ventricular arrhythmias, and that's sustained arrhythmias. So more than 30 seconds within a 24-hour period of time. Some people will say these episodes separated by 5 minutes. That's fine. But oftentimes we'll see this with monomorphic VT, but you'll also see polymorphic VT. You'll see VS.
All right. And what causes it?
So multiple causes. And I say it takes a lot of things to create the perfect storm. So typically, pun intended there. So typically, these are patients that have a substrate. So this might be your person with cardiomyopathy, more typically ischemic cardiomyopathy than non-ischemic cardiomyopathy. But it could also be that patient with channelopathy. So we're always thinking about Brugada syndrome, short and long QT syndrome. It can also be your patients that have an inflammatory or an infiltrative disease in the myocardium, arrhythmogenic right ventricular dysplasia. We don't really see Chagas disease that much, but we do see giant cell myocarditis and some of those other horrible things. And then also there's bradycardia-induced torsades and rhythms that we'll see as well. You have the person that has the substrate, and then on top of that, you end up with a trigger. So the triggers are the things that I feel like we talk about in our training all the time as resuscitationists. I would pound into our interns' heads ischemia when you see these patients come in. And so I think we're good with that. We also look for electrolyte derangements, thyrotoxicosis, things that cause increased adrenergic state. And I think most of us remember look for heart failure where they might have elevated LVEDP. But sometimes we forget some of the other things, infections that can cause this. It's always important to do a good review of their medications, make sure that they don't have a prolonged QTC. Clearly, if someone's hypoxic and has decreased oxygen delivery, they're at increased risk for it. Severely bradycardic. But it's important to remember you have someone with a substrate. Now you have a trigger, and then they can end up with these ventricular arrhythmias. Typically, to stay in storm where you keep having recurrent arrhythmias, these are patients that often have an ongoing physiological stressor and altered autonomic response as well. So altogether, that kind of creates, unfortunately, that I don't think the term perfect storm fits well because, as we both know, it's a horrible storm.
Indeed. Now, should we talk about the mechanisms of arrhythmia, or should we leave it for the people to explore on their own in the post?
How would I do this? I try to do a poor job of in 1 minute mentioning the 3 things, realizing that this is a deep dive. And if you want a lot more, go to the post. And actually, there are whole chapters on this. But know that there's a couple mechanisms. 1, reentry. 2, triggered activity. And 3, repolarization heterogeneity. So the reentry, I think a lot of people think about, I think of it as like an electrical impulse going down, hitting scar tissue. You have fast conduction going down one side, and then you end up with this kind of uniconductional block, so the impulse stops. Around the other side of the scar tissue, you have the slow conduction, and by the time the slow conduction kind of goes around that scar and gets back to that unidirectional block, that tissue is now ready to actually accept the impulse, and that you could just have this vicious cycle where you end up with an electrical loop that just keeps reactivating tissue. Classically, that's monomorphic DT. For triggered activity, we often think of that depolarization that hits us during repolarization, so that RMT, and we see that with our polymorphic DT, our torsades. And then the repolarization heterogeneity, I often think about these in like the ischemic patients, where they end up with that myocardium be having unequal repolarization and recovery from that. And so they're really set up for reentry and arrhythmias. That is a very undersimplified way of going about it, but just to give you guys an idea.
All right, now we get to the juicy stuff, immediate stabilization. So you have one of these patients. Now, I assume in order for it to be storm, they would have tried some stuff already. So they might have tried medication. They might have tried shocking a patient if they were unstable. And now the patient either has no response to it, or they might have responded to the shock and then immediately gone back to whatever ventricular arrhythmia they were in. And so now we're dealing with them and we're not happy. Usually you shock these V-tach patients, they're fine. And you feel great, you put them on an amnio drip, you send them upstairs. But that is not the patients we're dealing with here. So walk me through a progression on these patients, Trina.
Yeah, absolutely. So I like to break this down into pillars of management. And you're right. Most of us like to think they go into these rhythm, we shock them, we all take a deep breath, they're back into sinus. In fact, sometimes this rhythm I find less scary than sinus tach because I don't have to think as much. I just follow an algorithm. Sinus tach, there's a massive differential for it. So when it comes to the pillars here, I always say immediate stabilization is your number one goal. So clearly, electricity is going to come in because these patients are typically unstable. So for me, when it's monomorphic VT, classically, I have these patients upstairs, so they have an A line in. I'm not feeling for a pulse. I typically am doing a synchronized cardioversion, 200 joules right out of the door and starting there. Clearly, if it's polymorphic VT, VF, you're going straight to defibrillation. And you've talked about it at nauseum on EMCrit, so I think the audience all should know. You and I both are reaching for anterior posterior pad placement. In fact, that is my go-to. The only time anterior lateral pads are on the chest in my world is when I'm doing dual sequential, or on the very rare post-cardiac surgery patients that I know my surgeon's going to be really upset if I rip off the negative pressure dressing right over their sternum within 8 hours of them coming out of the OR.
Fantastic.
So that's step one for me.
All right, so we're going to shock them. We're going to do it right. We're going to go to dual sequential if that's not working. What now? So now they failed dual sequential defibrillation. We're really not happy. So what's next up?
So while I am shocking, the next things that I'm thinking right away, and actually before I jump into the next thing, one thing I want to say, because I find that when I worked in the emergency department, I typically would forget this. A lot of these patients that will be coming in, since many of them have cardiomyopathies, will have a pacemaker AICD in them. And so one of the things that is really important is you and I both know that shocks hurt. And sometimes they're having ineffective shocks that's actually perpetuating the storm. So one of the things that if they do have an implanted AICD, I am slipping a magnet over top if they're getting ineffective shocks and making sure that I'm having the pads on anterior, posterior. I'm also calling for someone to interrogate that. Now, not clearly if they're in the middle of, if I don't have them back in a perfusing rhythm, but if I get them back in a perfusing rhythm, because it's really important to remember that when they interrogate that pacemaker, one, they can see what rhythms they've been in, were the shocks appropriate. Two, they can adjust multiple things that are very helpful for us. So they can do anti-tachycardia pacing, where they're actually giving them pulses of rapid paces to try to get them out of this ventricular rhythm without actually shocking the patient. And your patient will love you for that. They can also do overdrive pacing if you get them successfully back into a sinus rhythm. So pacing them at a faster rate to help try to prevent ventricular rhythm reoccurrence. So these are all important things to remember that sometimes I felt like I didn't think about in the emergency department. So I just wanted to put that out there.
Yeah, now that we've brought it up, it's worth, I think, spending a few seconds on, because I don't think anyone ever taught me how these pacemakers are trying to handle dysrhythmias. And I think this is a nice opportunity to educate the audience. So a lot of these will already have things like anti-tachycardia pacing and overdrive pacing built in as ramp ups before it actually shocks. And that's going to be whoever programs the pacemaker is going to decide. Could you briefly explain how do these rapid pulses of anti-tachycardia pacing, ATP, what's it doing? What's happening there?
Anti-tachycardia pacing, or ATP, is basically when the ICD delivers a short burst of pacing pulses at a rate that's slightly faster than the VT that the patient is in. And the goal is to interrupt the reentry circuit that's causing the arrhythmia. The goal is that one of these pace beats hits excitable tissue in the reentry circuit and terminates the circuit, restoring normal sinus rhythm. So basically, an ATP beat enters the reentry circuit and collides with the circulating wavefront, resetting the circuit. This is analogous to successfully cutting into a busy traffic roundabout and stopping the flow of traffic. Classically, we're using this during active VT, and typically monomorphic VT from a reentry mechanism is often the times we find this maybe being the most successful. Your patients will love you for it because typically we can get them successfully terminating their VT without requiring defibrillation or synchronized cardioversion, for which they are always very grateful. Now, it's really important to depend on your friendly EP colleagues to be the brain behind this because the settings can be pretty complex. The other therapy to be aware of is overdrive pacing. And basically, you can think of this as pacing at a rate that's faster than the patient's intrinsic rhythm with the goal of arrhythmia suppression or termination. Technically, ATP can fall under the category of overdrive pacing as a specific form of it. Now, frequently, you'll hear us referring to using overdrive pacing for arrhythmia prevention, and that's one of the ways I discuss it in the post. So one example of how it could be used would be in bradycardia-induced torsades de pointe. Here, the slow heart rate can be associated with a very prolonged QT interval and repolarization time, making it more likely for an ectopic beat to occur during this vulnerable period and trigger an arrhythmia like an R on T. Overdrive pacing increases the heart rate and classically will pace them at a rate of 90 to 110 beats per minute, but this can be variable, which in turn can lead to shortening of the QT interval and repolarization time, help it to minimize this risk of R on T and torsades de pointe. Now, it's important to remember that overdrive pacing can be done with a patient's implanted device, but also with epicardial wires or transvenous pacemaker, and even technically with a transcutaneous pacemaker, although, as you can imagine, if the patient is awake, they will probably not appreciate you doing this unless you're giving them some decent sedation. So overall, it's just really important to remember that our EP colleagues can be really helpful in these circumstances. So make sure we're calling them early in the course.
Perfect. Now, let's say they're there and the shocks, they've interrogated, the shocks are appropriate. They're actually shocking a real VT. Are the internal defibrillator shocks less painful because they're lower energy because they're so close? Or are they just as painful? Or are they more painful? What's the deal on that?
I don't know that there's good data. I think our patients don't really think that there is much difference because you and I both know there is a lot of psychological distress in these patients when they come in and they're getting shocked over and over. Yeah. In fact, if this patient is in my unit and they're in slow VT, say 130s, 140s, and they're hemodynamically tolerating it, I will tell them like, hey, just make sure that you set their V2 threshold higher. I'll try to treat it with like antiarrhythmics because we're just increasing their endogenous sympathetic response. And I think it's harder to keep them out of it. So there's all those things. I think they hurt like hell. I'm not sure that a shock, that's why I shock with 200 joules on all these patients. I don't think a shock at 100 joules hurts less. And what hurts more is 2 shocks compared to 1.
Oh, go 360 because that's how ours go for the same reason. Yeah, we're on the same.
Your biphasics go to 360?
Yep. Yes. We talked about this with Chesky's. The company that isn't the one that goes to 360, they looked at it and said, there's no difference between 200 and 360. That's why. It's not like they couldn't go up. They're like, you study this, there's no benefit. 200, you keep getting up till that point, there's incremental benefit, and past that, Hey folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members-only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening. Don't believe that there is, and that's why they haven't added 360. So one of the major manufacturers has 360, the other one stops at 200. I don't think there's a difference based on their data.
I definitely don't think there's a difference in pain and maybe not outcomes. I'm just curious, does myocardial stunning make any difference with I don't know.
No, so the Catholics, they looked at, and I have a few of these studies, they looked at 600 joules, and there was no difference in troponin markers, in stunning, or anything. So I say go as high as you can and just go big or go home. All right, Trina, we talked about shocking. We're going to now talk about antidysrhythmics, and they're separate in our discussion. But honestly, if these patients have failed the first shock, then everything else should be happening simultaneously is what I've heard from you. Is that correct?
Absolutely. My nurses know this, but I am simultaneously infusing amiodarone, reaching for lidocaine right as my shocks are going on.
Okay, fantastic. So that makes sense. We'll talk about it separately, but ideally, you're calling for these meds as you're preparing to shock these patients. All right, you have an algorithm here, which is helpful because most people, they have their first choice drug, whatever it is. And then after that, it's, I don't know. In fact, and we should counter this myth. People have been told through the ACLS course for years that you only get one antidysrhythmic. I don't know if you were old enough, Trina, to be around when this was first introduced, but they hit it hard that you're going to have proarrhythmic effects from using more than one antidysrhythmic. And whether that's true or not, that's really only applicable to patients who are in a standard non-storm state, right? Like they had a dysrhythmia, maybe 20 hours later, they have another one. Okay, fine, don't mix. But electrical storm, that's not applicable. You want to have a cocktail here. So walk us through your algorithm.
Absolutely. What I've learned is in these moments, everyone's adrenaline is high and it's like high catecholamine state for not just the patient, but for all of us. So I try to simplify this. So I recommend people look at the algorithm, but what I'm going to do is tell you my approach to keeping this simple and in the moment. So one of the first things that I'm doing is I'm infusing amiodarone. For me, that's typically, you can clearly, if they are coding, you can be doing the 300 milligrams, just a push in. If you have a little bit more stability, I'm still giving the 300 milligrams. Typically, that's 150 milligrams over 10 minutes times 2, which is 300 milligrams over 20 minutes. And I'm not shy with it. I am very happy to hang that third bolus right away. Technically, guidelines would say you should stay under that 5 milligrams per kg in that first hour. For most people, if you're talking an 80 to 100 kilo person, that gives you 3 boluses right there. And then I'm starting the drip right away. Now, there might be times I'll even reach for that 4th bolus, and especially on ECMO patients, and we can get to that in a little bit. So there again, start right in, be pretty aggressive with amio, get that started. From there, I'm reaching for lidocaine. Here again, I try to keep it simple. So per guidelines, I'll say you go 1 to 1.5 mg per kg for your first bolus, followed by 0.5 to 0.75 mg per kg. That's masked. You and I both know those pink boxes come with 100 milligrams in them. I push 100 milligrams. And if they're still in the rhythm, I grab my second box, push that. So there's about 200 milligrams on board. And then I typically will start a drip at 1 milligram a minute. Guidelines recommend less than 300 milligrams an hour. And that puts you right at about 260 milligrams. So it's keeping you safe. It's without having to do much math.
All
So
right.
that's kind of my approach to those two.
Let's pause. So first and second line, I think people are going to be pretty happy with. Your third line, which is going to be procainamide, people might have a little bit of a frowny face, but there's some other meds here, and I'm curious where they fall into this algorithm, whether they precede this third line or not. So beta blockers, where do those fall in? Are these going to happen before the procainamide, or is the procainamide going to happen first?
We're coming from the patient. So if it's the patient that you have shocked and they are in electrical storm, sure, but you've shocked them twice, you've got those antiarrhythmics on board, and you're now in a sinus rhythm. You have a hot second to throw an ultrasound on their chest, and it looks like they have pretty normal function. You're looking at this young person in front of you, and you're starting to wonder, do I have a channelopathy? Do I have something else going on? Then I might be ready to reach for my beta blocker. We know that we have good guideline support for beta blockers because these patients had this increased adrenergic storm, and it's often this increased beta agonism that is driving the storm. So blocking it just makes sense. And you can start with drugs that have a very short half-life. So esmolol, or if you're lucky enough to have it, landidiol. I think our institution just got it, but it's just been recently FDA approved in the US and actually only FDA approved, I think, for AFib, a flutter. I think there's some other countries where it's actually approved for VTVF. So that's something to think about. But now, if you're talking to the patient that's in front of you that you're on shock 5, sure, you're getting transient thymus rhythm, but you were nowhere near being able to have the stability where you can quick look at their heart, or they look like the acute decompensated heart failure in front of you that you're worried about at low cardiac output syndrome, then typically I'm a little hesitant to pull those out. We have a little data in the cardiac arrest literature that looks at esmolol in cardiac arrest patients in refractory electrical storm or VTVS, and that there might be a suggestion of a decreased mortality, but not great data. You and I both know. And there's also data with landidiol in some of this population that actually didn't have great results. So I'm pretty hesitant to pull out a beta blocker if I'm worried that this is someone that's acutely unstable in front of me or with a significantly decrease in their ejection fraction.
All right, that makes sense. And you've made a note that amio, in addition to its class 3 effects, is also a beta blocker and a calcium channel blocker for that matter. So you're getting a lot of blockade from the really high dose amio we're talking about here anyway. All right, so this one, I think, is going to take some joy away from many ED docs because they just love their magnesium. But I can't find a lick of evidence for magnesium in monomorphic VT, even though everyone's giving it. Now, clearly in polymorphic, that and potentially even pushing their potassium up a little bit high if it's at low normal would be worthwhile. Are you giving mag just across the board, or are you only giving it to polymorphic VT?
I'm laughing because my incredible physician assistants will invariably have ordered the 4 grams of mag to go in, which I don't think it's doing harm, although it can cause, your patients to be uncomfortable and some of that, flushing if they are alert, but that's a good sign if they're alert and able to complain to you about it. But I don't see benefit specifically in monomorphic VT. And you're right, the drug algorithm we're talking about here, I've been focusing a lot on monomorphic. It's very different. And I talk about this. It's important to target your drug therapy to what's going on. So if you have polymorphic VT that you think is due to a prolonged QTC, i.e. torsades, clearly that's very different. There you're attacking with large doses of mag, you're correcting their electrolytes, you are even reaching for things like transvenous pacing or speeding up their heart rate with isoproterenol, which is very different therapy than what we're talking about from monomorphic VT.
All right. So now we get to the third one on your algorithm, procainamide. And are you worried about the hemodynamic stability in these patients?
So I'm laughing because I love procainamide, but I realize that it's a drug that a lot of people hate. My first introduction to it was when I used it for chemical cardioversions in the ED. And I love to do the 17 mg per kg, typically 1 gram over 50 minutes. Yeah, it wasn't as effective as electrical cardioversion, but it did save me from having to shock a lot of patients, and they really appreciated that. So I got used to using it there. And then when I came to the ICUs, I found that it could be really helpful on some of these patients that are in electrical storm. Do I worry? Of course I worry. And if you read the wordings on procainamide, they all talk about the risk, especially when you start adding it to other antiarrhythmics like amiodarone, of seeing increased QTC prolongation, QRS widening, hemodynamic instability, all of these things. But I argue when you are at that point with this patient here, and you are many shocks in, you're reaching for this antiarrhythmic, you're at not a great spot. So at this point, your hope is that this drug will help you convert them. And sometimes you have really good luck with it. I try to simplify it. Here again, I like to play off of what I was comfortable doing in the ED. So, I know that, hey, I can pull for a gram. What I tend to do is pull up 300 milligrams right out of that. And I'll push 100 milligrams over 2 minutes times three and just see if I can actually convert them right there. If they convert, I'll stop. If not, I'll hang the rest as a drip over the next 20 to 50 minutes and let that infuse. I typically don't start a drip because you're right. It has a very narrow therapeutic index and there is a real risk of side effects with it.
All right. Now, we're at the point in the outline to talk about stellate ganglion block. But for me, I would not be getting to stellate ganglion block at this point. I'm curious to see if you disagree or not, because if I'm going to be placing a stellate ganglion block, I'm already going to have the patient intubated and sedated. And that alone may actually be a therapeutic option. You put these patients at a deep state of anesthesia with propofol and fentanyl or what have you, and that might be enough to get rid of the adrenergic issue causing the electrical storm without worrying about beta blockers and without having to do a stellate ganglion block. Trina, are you placing these blocks on patients who are not yet intubated in electrical storm?
We do on occasion. I will say that. But what I'm laughing about is I don't know if it was pregnancy insomnia or what, but I woke up at 3 o'clock this morning. I thought to myself, I should have reordered that in the post because typically, especially in ED, I 100% am intubating, sedating. I'm shocking getting the drugs, then I'm intubating and sedating, and then the stellate ganglion block goes in afterwards. So full confession, it a little depends on the environment I'm in and also what resources are available. I think from an emerge perspective, I'm focused on that initial, let's stabilize, we shock, antiarrhythmics. And at that point, I mean, if you're shocking them off in any ways, this patient needs sedation, they need pain meds. We need to be kind doctors. So tubes going in and exactly what you're saying, sedation was a form of treatment itself. So I'm putting them on deep sedation, typically propofol, fentanyl, dexmedetomidine. And in itself, you and I both seen, sometimes that's enough to get you quiescence. You can successfully defibrillate them and you're at a much happier spot. Typically, if they've been shocked that many times, though, I'm already still thinking it's time to get the stellate ganglion block going. Then it's really easy. You've got an intubated, sedated patient. And also, if you need to do bilateral, they're intubated. You're not as worried about the phrenic nerves.
Yeah. And I got to say, I think you can get away with it if you feel really comfortable. But by the time I'm given a few shocks, I ask myself, my patient would probably really enjoy not being aware. And if they're going to have to take a trip to the lab, and they probably all should for one thing or another, it just seems like easier all around from an emergency perspective to just take the airway. And as it continues, their hemodynamic stability kind of ebbs, and that's not the greatest time to then have to grab an airway. I think intubating early in the emergency department is not a bad idea at all. Okay, so now at some point, either they're going to get intubated and get a stellate ganglion block. Probably that's going to be the situation in emergency medicine for the most part. Maybe in a specialized environment, they might be getting it without. And in that latter case, would you be giving dexmedetomidine to those patients before the stellate ganglion, both for its advantages? That is in and of itself an adrenergic blockade, but it's also going to make the block and further shocks much more palatable. So when do you fit that in? When do you fit in the dex, Trina?
Yeah, so I like the dex on both intubated and non-intubated patients. So for me, it's going to fit in pretty early. There's some decent data, clearly not perfect, but we do have an RCT, I think the sedate trial also that's going to be coming. And that's actually using dex as first line on non-intubated patients, which I'm super excited about. So I think I've found in my practice that with dex, you can, especially if you're titrating it to the right dose for the patient, you can use it very nicely with minimal respiratory sedation, respiratory depression, minimal sedation. And using it early, I don't see many downsides. Now, there are some people that will have significant hemodynamic side effects from it. So that is something you'll have to watch for. But you can also counteract that with a little bit of low dose vasopressin or norepinephrine.
what are you starting your dex at for these patients? Obviously, you're not giving a bolus. So what are you starting the drip at?
So for me, and that's partially because I'm so used to unstable cardiac patients upstairs, I tend to start it lower, maybe even zero point 0.3 micrograms per kg per minute. And then if they're awake, I tend to see a lot of people, I don't go much above 1 mic per kg per minute. It can be a little bit variable, and you'll have those patients that at 1.5, or some of my anesthesia colleagues, we can go as high as 2.1, will be like doing great. But then there's the other person that will become very hypotensive, or if they're in sinus, they might go bradycardic, or they might end up with actual significant sedation. So I start a little lower and then just stand there at bedside and just keep titrating up.
All right. So we're going to get some sedation on board, or we're going to intubate them. We're going to put in a left-sided stellate ganglion block. At what point in this algorithm do you pull the trigger on bilateral stellate ganglion blocks? And I'll give you, the patient's intubated, so you're not worried about respiratory depression.
Yeah, there's not great data on it, but there's, I think, a point where we're like, hey, if they're intubated, we are still going into refractory VTVS. We're starting to think this patient is heading for ECMO. It's worth a try. At this point, you're throwing what we say the kitchen sink at them. What I would say is that if they're not intubated, I rarely will reach for this, because it definitely can happen. And it just happened in the last week or two where we took on someone's phrenic nerve and they ended up in the ICU on BiPAP because we did bilateral stellate ganglion block. So it's a real risk. But I think if the patient's intubated and you are still in refractory VTVF, it's worth a try, because at that point, you're heading for the pathway for VA ECMO if you're getting down to that part.
All right. Now, under the sedation category, we could talk about sedation for the actual shocks until the patient's intubated. And I just can't stress enough. That's why, because this gets to be a real pain in the butt for anyone who's done it, because you're like all excited. You get just like you're going to do a cardioversion. You give them whatever you like, and they're all happy, and you get them perfectly sedated. The nurse is writing down the vitals, and you shock. And great, everything's wonderful. But now the second one happens, and you're like, what, do I have to do this resedation paperwork? And now the third and the fourth, it gets to be silly after a while. And I've seen some of the not particularly nice cardiologists, and they're very rare, who are just like, you know what, we just have to do what we have to do at this point. We're not going to go through this whole rigmarole, and it's horrible. So that's when I'll say, okay, we're just going to intubate this patient before that happens. But let's say for these first few shocks before the patient gets intubated, what do you prefer, Trina?
I love that you're bringing this up. I was hoping we'd have this talk. I tend to be a remimazolam girl. I grew up in my ED time. I tended to do etomidate, but I've merged to remimazolam, and I've come to love the drug. Part of that is maybe in my ICU practice, I found that it's so easy to titrate. It doesn't dose stack because it's such an ultra short-acting benzodiazepine, onset within a minute, peak effect within 3 minutes, and its offset is real quick. So I found it to be pretty hemodynamically stable. I can dose it with minimal respiratory depression. I basically shock. Patients wake up and they say, what did you do? So I love that. Now, at the same time, I'll say I can use etomidate and do something pretty similar to that. Typically, I'm shooting a dose more like 0.1 mg per kg, so pretty low dose etomidate. One of the reasons that I had been moving away, especially with trainees towards remimaz, is that I've seen it being more challenging for them to dose etomidate appropriately. And I've seen a little bit more apnea and jaw resting, and it works, but I've seen it a little bit more. So that's been my practice pattern as of late. But I truly think you could use either of those as well as other drugs and do this successfully, but you have to be very careful on your dosing.
Yeah, that's very fair. How much remimazolam do you give to start with, and then how often are you titrating?
So it really depends. So it comes in a vial in like a powder-like form that's at 20 milligrams in the vial. I reconstitute it with a 10 ml flush. So I've got 2 milligrams to 1 ml. And so it depends on the patient, age, comorbidities, all of that. The least I've ever used for a shock is probably 2 milligrams. And that was on a patient that was like very unstable, like a little altered already. And they did great. They fell asleep, woke right back up. Typically, most people are going to need more. They're going to need more on the upwards of 4 to 8 milligrams, sometimes more than that, but it's really variable. And so I start by pushing typically about 4 milligrams, seeing how they respond, adding a little more if I need.
All right.
And it kicks in quickly.
Let's talk about hemodynamic support if these patients are getting a little bit soft on their blood pressure here. I obviously have a very low threshold to just start them on vasopressors. With the knowledge it's a temporizing measure, because what they need is their heart to function. And here we are squeezing their vasculature. And so it's not a great long-term solution. We got to do what we got to do. So what do you like in these patients, Trina?
Yeah, this is, and I put this in the blog too. This is a big time like data light zone. And I say proceed with physiology and caution, which is, I think, a motto that we should keep in medicine all the time, anyways. My preference typically in my reaching for drugs are going to be vasopressin and norepinephrine. The big thing I try to remember is a lot of these patients have increased adrenergic drive. What you want to do is try to stay away from beta agonism. So clearly drugs like dopamine, which I guess I barely even think about anymore these days, but then epinephrine, dobutamine, stay far away from those drugs. Classically, people will reach for phenylephrine and vasopressin. My caution is exactly what you're saying. That's a patient though that came in with decompensated heart failure, who's in monomorphic VT and who has an EF of 15%. And now you suddenly put a lot of straight up afterload on them. You can lead to ventricular arterial decoupling, where basically they end up going into worsening cardiogenic shock, higher LVEDP, and you're just going to set yourself up for more refractory arrhythmias. So for patients that have a normal EF and I just need to combat the sedation that I gave them, vaso, I guess if you want to pull phenylephrine, fine. But if it's a patient with a little lower ejection fraction, they have worse myocardial stunning or cardiomyopathy, I tend to find norepinephrine, the tried and true drug that many of us are so comfortable with, the great go-to, which is great because I like to keep stuff simple in these moments.
Yeah, I was going to say, I'm not as smart as Trina, so I just reach for the norepinephrine because anytime I don't have to make a decision, I am a happy man. All right. So now I think in my mind, all of these patients should be going to the lab as soon as possible. And then the cardiac guys and gals upstairs could figure out what they need, whether it's an ablation or a cath to look for ischemia, et cetera. Are there patients who you would do anything else downstairs before they would go to the lab?
Now, I think if you have done the stuff we've talked about, you have went above and beyond. I think the one thing to think about downstairs is, say you have that patient that you've done all of this, you are now escalating on pressors and you are not at a good spot. That would be the time, and we'll get into this, to call for VA ECMO, because there are times when, you need to actually get them on VA ECMO to try to stabilize them, because they are going to just code for you and you are going to be in an ECPR situation. So otherwise, though, absolutely not. You should be setting these patients up, because if it is, and you and I both know this, if there is a blockage, the goal would be to get that open as soon as possible. And that's going to help you actually get them out of this rhythm.
All right. Give us 1 minute on what they would actually do in the lab. How do they always start with a LV cath, or do they, depending on what they found on the actual EKG, make a decision? Oh, no, I don't think this is ischemic. What's their thinking on this? If you could put yourself in the mind of these cardiologists, Trina.
I think for the most part, most of these patients are going to get a left heart cath. Maybe if it's clearly a bradycardia-induced torsades de pointe from QTC prolongations, that's a different scenario. But for the rest of these, especially they come in with monomorphic VT, yes, it could just be that this is scar tissue and that's what you're kind of left with. But most of us want to rule out any new ischemia. And typically, they're not doing ablations right when they roll through the door. Our interventional cardiologists are doing the left heart cath looking for blockages, but typically our EP docs that are actually doing these ablations. And so ideally, we get them stabilized out before they are heading for that ablation. And I typically see those ablations happening a day later or down the road. Clearly, they're important, and there's a platform indication for it in electrical storm that is refractory to medical management in both ischemic and non-ischemic cardiomyopathy.
All right. So now we have a patient that is either so unstable that you're like, they're not going to make the trip up to the cath lab, or they're already in the cath lab and their stability is such that they're not going to make it through a intervention. And so now the idea comes of perhaps a protected trip to the cath lab or in the cath lab itself. So when should we call for mechanical circulatory support, and take us through the escalation cycle on this?
Laughing. The classic phone call I get is, "Hi, Dr. Augustine. We've given about 30 shocks. We're on 3 antiarrhythmics. We're on norepi at 0.25, vasopressin's on, and we've got a blood pressure of 60 systolic." And I look at the monitor as I pull it up, and it's like you can just see shock, go back into sinus, like 30 seconds later, shock. So that's classically, and since my team, we do VA ECMO and we do the stellate ganglion blocks, we get it all lumped in together. But the question is, when should you call? It would be nice to have great guideline support. And the American guidelines don't give us a lot of help on that. The European Society guidelines do say it should be VA ECMO is a class 2B recommendation. So consider it an electrical storm that is refractory to medical management that's complicated with cardiogenic shock. And then they also say you can consider prophylactic initiation for patients prior to catheter ablation if they're considered high risk. So, what I say to keep it simple for people is you want to call when you've exhausted medical management. And if you have this patient, you've done all the things we've talked about, they're on 2 vasoactives, and one, you're still having a hard time managing their hemodynamics, or you feel like your vasoactives are actually causing worsening of your arrhythmias or causing the patient to have a hard time ejecting, that's one call. The other thing is call early before they're in multi-organ failure, because it's really, our outcomes are better if we put them on sooner. And then periprocedure support is kind of a whole other thing, and that's typically my P colleagues who are calling me about that.
All right. I love the idea of getting lifelines in these patients because then it's not really as much of a clusterfuck. I'm sure when you come in, it's no problem. You can get a arterial access in pretty much anyone, but it's a game changer to already have confirmed good lines in and placing a patient on rapid crash VA ECMO versus not. And assuming they might want that right femoral artery left alone for the lab. So if you placed an arterial line in the common femoral artery on the left and put a central line in a femoral vein, I don't really care which side at that point. Nicest would be on that right side, but whatever you get, and just left them there, that would be incredibly helpful for these patients. Trina, what's your feeling on that? Do you not want anyone mucking with your vasculature and just leave it pristine, or do you like the idea of the team putting lifelines before you come?
So I realize that I'm in an institution that probably has more bougie resources, meaning me or my colleagues are there 24/7. So frankly, I like the phone call because I'll tell you this, if we're called and it's, hey, we think we want a stellate ganglion block, this is what's going on, I'm stellate ganglion block putting placeholder lines in right away. So that's my go-to. And in fact, we know from cardiology's data that it should be a radial first cath approach at this point. There's a lot less complications. So they should be using the radial. So you really should be able to take either femoral artery you want. I tend to also go left common femoral artery and common femoral vein. But yes, placeholder lines, whether it's me doing it, whether it's the ED doing it, whoever can put them in the nice spot in the common femoral vessels, that's perfect because you're absolutely right. If you have placeholder lines in, we can get you on ECMO support really quickly. And that's super important, especially if you're at a spot where you're ending up doing chest compressions and everything. It's a whole different ballgame.
All right. Where should we go next, Trina, with the understanding that the stuff that's happening in the lab, probably most of the listeners they could go to the post for that. Is there anything else we should talk about for part 1?
Oh, I think the big thing for people, for emergency medicine doctors and then critical care doctors who aren't specifically working in cardiovascular ICUs is to know that VA ECMO is very helpful in the fact that, one, it's not only providing hemodynamic support for all of these procedures to allow your AEDs to work and also potentially bridging to advanced therapies, but it can also sometimes help to be treated on its own. You can back off of your vasopressors, and especially if you're on inotropes, it can reduce adrenergic tone. You're increasing oxygen delivery, so helping to prevent your patient from going into multi-organ failure. So it can be really important for a lot of different reasons. So I think it's just important, remember, call early. We see all these dismal outcomes on ECMO and we don't have great studies. And I'll say there's not great studies for electrical storm and VA ECMO. And when you look at retrospective studies, survival is anywhere from 40 to 80% in these patients. But what I will tell you is, especially when you have those young patients with channelopathies and things like that, these patients do really well if we can stabilize them on ECMO. So remember, call early, involve us, and we want to work together to have the best outcomes for these patients.
Love it. All right. We will call that part 1